A pulmonary infiltrate is an abnormal area of whiteness in the lung fields. In addition to lung pathology, abnormalities in the pleural space may give rise to this appearance. A pleural effusion is a common cause of whiteness on the chest X-ray. Fluid in the pleural space is usually free to flow within the chest cavity under the influence of gravity and conforms to the shape of the cavity it occupies. In an erect patient, the pleural effusion collects at the base. The diaphragm margin is lost and there is uniform whiteness in the lower zone. In the absence of a coexistent pneumothorax, the fluid curls up at the margin of the chest wall due to surface tension, and this is known as a meniscus sign. In the supine patient, the fluid accumulates posterior to the lung. This gives the lung a uniformly veiled appearance. Occasionally, fluid can be seen beside the lung in a similar fashion to the meniscus sign on the erect film. To be visible on the chest X-ray, at least 250 ml of fluid is present. Pleural fluid usually gives a homogeneous infiltrate and lung volume is maintained. The presence of patchiness, lung volume loss, or air bronchograms suggest the presence of other pathologies. Alveolar opacity causes dense whiteness. It is usually patchy, and the hallmark of this pathology is the presence of air bronchograms. Because fluid usually settles with gravity, the density is often most at the more dependent area of the affected lobe. Pneumonia is a common cause of alveolar opacity, although other causes do exist, including marked fluid accumulation in the alveoli due to ARDS or pulmonary edema, or due to pulmonary hemorrhage or other pathologies. Interstitial pathologies cause a nebulous greying of the lung tissue. Often this resembles the appearance of ground glass. This CT scan demonstrates the difference between these appearances. The white arrow demonstrates ground glass opacity, and the vasculature can be clearly identified coursing through the lung tissue. The black arrow demonstrates the very densely opacified appearance of alveolar shadowing. Infiltration of the interstitial space can give rise to characteristic patterns reflecting the interstitial anatomy. For example, in this patient with pulmonary edema, fluid can be seen lining the interlobular septae. These appear as short, non-branching horizontal lines in the peripheries of the lung. With increasing pulmonary pressures, Starling's forces lead to a gradual extravasation of fluid into the interstitial space and in the pleura and fissures. Further increases lead to fluid accumulating in the alveolar space. This fluid classically accumulates in the perihilar region, in the so-called bat swing distribution. However, this is relatively uncommon in clinical practice. A number of factors, including increased pulmonary capillary permeability and reduced plasma oncotic pressure, result in extravasation of fluid into the interstitial and alveolar space in ARDS. The result is a mixed heterogeneous appearance of the infiltrate. The definition of ARDS is standardized as follows: acute pulmonary infiltrates, severely impaired oxygenation relative to inspired oxygen, and the absence of evidence of increased left atrial pressure. Telling the difference between cardiogenic edema and ARDS can be difficult. The presence of a large heart is suggestive of cardiogenic edema. However, ARDS may occur in patients with pre-existing heart failure, and APO or pulmonary edema may be present in some patients with a normal-sized heart. The presence of large pleural effusions is more likely to represent pulmonary edema. The distribution is also said to be a useful discriminator, with acute pulmonary edema described as central and the ARDS syndrome more global or peripheral in distribution. However, these findings are not particularly reliable in practice. Generally, other clinical and investigatory findings are required to distinguish between the two entities, and the underlying pathology consistent with a cause of ARDS should be sought before the diagnosis is made. Multiple similarly sized rounded lesions suggest hematogenous metastasis. The most common causes are breast, gastrointestinal tumours, renal tumours, melanoma, sarcoma, some blood-related cancers, and germ cell tumours. A pulmonary abscess is a cavitating lesion in the lung. The presence of an air fluid level is highly suggestive. It may be difficult to differentiate from a cavitating malignant lesion. It has been suggested that the thicker the free wall of the cavity, the more likely it is to be a malignancy, with 5 mm being the common cut-off point. A commonly seen but under-recognised cause of an infiltrate is upper zone hyperinflation, which is commonly seen in smoking-related emphysema. The hyperinflated areas of the lung effectively squash the lower zones, crowding the vasculature and giving the appearance of an infiltrate. Causes of a white lung include massive hemothorax or hydrothorax, total lung collapse, or total lung consolidation. Often, the clinical scenario and examination findings will clarify which of these is the cause. Pneumonectomy may also cause this appearance. The position of the mediastinum can also assist. In collapse, there should be a shift towards the area of whiteness, whilst sudden massive fluid collections will push the mediastinum away. Total lung whiteout from consolidation is unusual. The mediastinum would be expected to stay in the midline, and air bronchograms should be visible.